Hello, you're watching EASD TV. My name's Vivian Parry, and in this session we're going to look at something that's of interest to diabetologists everywhere: cardiovascular disease in those living with type 1 diabetes. And the session that we're particularly interested in is called the 3 Ps: prevention, prediction and pathogenesis. And we've got 2 of those 3 Ps with us. We've got Andrew Paterson, who's going to be talking about pathogenesis, and Helen Colhoun, who's going to be talking about prediction. And we would have also had Tina Kostaku from the US talking about prevention, but unfortunately she broke a leg, so she isn't able to be with us. Tina, if you're watching, we hope you mend quickly. So let's start with Helen, because your topic is prediction. Are we good enough at predicting cardiovascular complications in people living with type 1 diabetes?
Well, I would say that we can make much greater strides in that prediction than where we're at the present time. At the present time, we tend to have a one-size-fits-all approach to predicting cardiovascular disease risk in type 1 diabetes. We know, for example, that people with type 1 across all age groups on average have a 2 to 3-fold increased rate of cardiovascular disease. And we also know that it continues to be the single biggest cause of the loss of life expectancy in type 1 diabetes. We also know that it is also continues to be a major cause of early deaths below age 50 in type 1 diabetes. So those are very broad statements, and they convey the magnitude of the problem and the need to be very vigilant and to step in early in the prevention of cardiovascular disease in type 1 diabetes.
But for those working in primary care, for instance, that's the message that they hear from diabetologists, and so they probably all think, well, what can giving people statins from a very early age, what can that harm? And just do it anyway.
Okay, so I think it's important that in this modern era where we are not practicing paternalistic medicine but engaging with people with diabetes, that we have conversations that convey more accurately what that individual's risk profile is and what that may mean for them. But it's very difficult to do that without having some tool at your disposal to calculate the individual risk for a person. So that's one of the things we have recently produced and are now taking through into medical device development. Broadly speaking, we have very generic statements in many guidelines saying that all adults with type 1 diabetes are at increased risk of cardiovascular disease. That's not very helpful if you're, let's say, a 27-year-old with type 1 diabetes and you're trying to have a conversation with your clinician about whether you should start statin therapy or not. It's more helpful if you have an indication of what your 10-year risk is and how your lifetime risk might look like, and then have a sensible decision, because you may decide that you want to start preventive therapies early, even if your 10-year risk isn't very high. You may decide that, but that's a different conversation from being told you're all at very high risk in the next 10 years if you're not. So I think it's very important that we not be alarmist to young persons with type 1 diabetes, but at the same time get the balance right with respect to prevention.
Andrew, let's turn to you now. You're talking about pathogenesis, and I know genetics are a part of this. So does that feed into the prediction models?
Yes, some of the work that we've been doing recently has been examining whether a genetic risk score, which is a combination of different genetic variants from the genome.
So a polygenic risk score?
Yes. One calculated for coronary artery disease in the general population, whether that also applies to people with type 1 diabetes. And using data from a large clinical trial, the DCCT study, we showed that this polygenic risk score is associated with cardiovascular disease risk in people with type 1 diabetes. In addition, we showed that even when we include the conventional risk factors, this genetic risk score is an independent predictor of cardiovascular disease, indicating that we still don't understand some of the mechanisms of cardiovascular disease in people with type 1 diabetes.
So in attempting to predict, you're also finding that there are still a lot of questions unanswered and opening up new avenues for research.
That's right. And they may also open up new places where we can intervene in terms of reducing risk for cardiovascular disease in people with type 1 diabetes.
Now, I know that you can't speak for Tina, but what about that other bit of prevention? Do you have a thought about that? I know you can't speak for Tina, but...
Well, yes. So there's a lot that we do know about cardiovascular disease in type 1 diabetes. So we know that important predictors include, for example, very importantly, your blood glucose control. And of course, we also know that new devices are now really helping people with type 1 diabetes to achieve much better glycemic control. However, there remains sizable fractions of the population with type 1 diabetes who never get anywhere near optimal glycemic control, and that continues to be a major driver of cardiovascular disease. Other risk factors, which are also risk factors in the general population, apply importantly in type 1 diabetes as well. For example, smoking prevention, and we continue to have, for example, in our population, a sizable proportion of people with type 1 diabetes who smoke. So I think it's very important in the clinic to check, is your patient smoking, and have you actually referred them to get help to cease smoking? We also know that lipids, your cholesterol level, as in the general population, is a very important predictor of cardiovascular disease in type 1 diabetes, so it's very important to have lipids checked regularly and managed properly. And then, of course, blood pressure management is extremely important as well. Achieving tight blood pressure control is very important for preventing cardiovascular disease and for protection of your kidneys and your eyes. So these are the mainstays of preventive policies in type 1 diabetes.
Just one more thought to you, Andrew. Where is this field going next? It seems to be moving now quite rapidly.
So based upon a small drop of blood, we can calculate genetic risk scores for thousands of different diseases in the population, and that can potentially give us opportunities to identify individuals who are at the highest risk for developing a particular outcome and potentially intensify their treatment related to that.
And then, of course, we've got all those behavioural things that are difficult to do. So there's a lot of work to be done here. But I know that people will be grateful to have had you outline this, because it's such a major component of people's work. So very interesting session there, and you'll find the whole session, of course, online at EAST web service, and where you will find, I think, Tina, who has probably done her talk online with that broken leg. Bye for now.